Hello, my name is Dr. Melissa Stiles with the UW Department of Family Medicine, and I'm happy to again be joined by Dr. Jeff Patterson, Professor of Family Medicine. And today we're going to be talking about low back pain, Part 2, management. Welcome, Jeff.
Thank you. Once again, it's great to be here.
So we've talked about evaluation. Let's talk a little bit about the outcomes for someone who presents with low back pain.
Well, the issue with low back pain, again, is acute versus chronic. And acute pain is something you really like to see in your office because the vast majority of those patients get better no matter what you do. And so you look good, the patient thinks you're great, and that's a real victory for everybody involved. Unfortunately, there's a percentage of people, probably 40% or so, that will have recurrences of their back pain. And then the risk is that this becomes chronic in nature, which means pain longer than 3 to 6 months, depending on the definition. And this clearly interferes with work, with social life, and just life in general for many, many people. And it's an anathema for most physicians. Most physicians don't like to see chronic low back pain because it is, let's face it, a difficult condition to deal with and treat. So that's the area that I'd like to focus on the most here today, because most of the papers that you read and most of the literature is on how to treat acute back pain. And,
well, let's briefly talk about acute low back pain. What are the beneficial treatments? And then
I think the things that have been studied show benefit. First of all is early mobility. Rest for 2 to 3 days, but really no more than that. And it's been shown that keeping people in bed for a week or longer actually worsens the situation. So early mobility, getting back to just regular activity. It doesn't have to be anything great, but just walking, moving around. We're made to move. If we don't move, we get rusty. And obviously in our society, we see plenty of that. Rusty people, I guess. So I think early mobility, and I do that along with muscle relaxants, especially taken at bedtime. Muscle relaxants can make people foggy and feel drowsy and whatnot, but at least taken at bedtime, I think, is a reasonable thing. And pain control. I think there's plenty of good evidence that adequate pain control probably is a real important thing in terms of preventing neurological sequelae, i.e. nerves becoming hyperactive and developing a sort of a neurological chronic low back pain. So I don't hesitate to give people even opioids for an acute low back situation to get them through that first period. Heat, I think, and I tell people try heat and ice both and see which feels better for you. And for some people, combination or one or the other, but people should not lay on a heating pad longer than 30 minutes. Heat should be intermittent, on 30 minutes, off 30 minutes. And the same probably with ice that way too. And some people find alternating heat and ice can be helpful as well. Other things that have been shown to be helpful are manipulation, osteopathic manipulation, chiropractic manipulation are done by other providers as well, can be quite helpful, along with massage in that for acute low back pain. And that actually has been studied and shown to be helpful. So I think for the acute situation, those are the things really that I would recommend. But the main thing is getting people moving.
Okay. Yeah. Well, let's focus on chronic low back pain. What are the most beneficial treatments?
So I think when I think about chronic low back pain, first of all, as we previously talked in the previous discussion, the history and examination is extremely important. And we often see on imaging studies degenerative changes. We all have degenerative changes as we get old enough, and those might include degenerative disc disease, facet joint disease, etc. But the question is that really the cause of the pain? And I have come to believe that probably the most frequent cause of pain per se is in the ligaments. The ligaments are the supportive structure in the back. And one of the ways to look at this is that you get a herniated disc. The disc is simply a bag of water sitting in there and kind of a firm tire surrounding. And what is really holding that disc in place are the ligaments, the tough white fibrous tissue that holds the bones together. And so when those ligaments get weakened, then the disc takes a pounding and ultimately ruptures. And the rupture is kind of the final thing, the straw that broke the camel's back, if you will, of a long period of weakened, increased motion due to ligamentous laxity. So I think improving muscle tone, exercise again, and then treating ligaments, which are a source of radiating pain, numbness, tingling, weakness, as well as, again, instability in the back that may lead to degenerative disease is probably very important. So first of all, the evaluation and palpation of the back to find out what ligaments might be involved. Pressing on a ligament is a diagnostic test. When somebody has tennis elbow, we press on their elbow and they say, oh, and you say, oh, that's tennis elbow, and that's a ligamentous problem, okay? And the same thing is true in the low back. Ligaments are very specific where they attach. Once you learn those anatomically, you can often tell a lot about the cause of people's back pain. Now, they may have a herniated disc, they may have bulging discs, but I would say a fair share of the time, those are really irrelevant to what's going on to cause the pain. So then I think focusing on exercise, again, exercise has been shown to be one of the more important things here, and I give people specific back exercises that I start them on. They're very easy. I call them desk exercises, so people can do them several times a day. And the hardest thing about exercise is doing it. It's much easier to take a pill. It's hard to do exercises. Sometimes you think, oh, my back hurts, I better get up and do a few exercises. But when you're sitting for long hours and don't do anything, that's bad for your back. And that's been shown in multiple studies. So exercise and real regular exercise, meaning 4 to 5 times a day, doing very simple exercises, I think is one of the keys to this. Medication, perhaps, but I think long-term medication may not be that helpful in chronic low back pain. We went through a period of prescribing lots of opioids for people, and I think most of us have kind of moved away from that now. The gabapentin or Lyrica drugs can be useful in terms of treating back pain. But again, I think these need to be used in conjunction with exercise programs. Other things that have been shown to be helpful are Tai Chi and yoga. And I prefer the Tai Chi. It's a little slower and gentler. And I've seen some people get into yoga classes where the instructors really push them to do lots and lots of stretching, and it overexerts their back and actually hurts them. So one needs to be very careful when entering into this that you have an instructor that knows what they're doing. And I think the other things that people can do, obviously physical therapy. Most people I see with chronic low back pain have been through tons of physical therapy and may have been through other programs. And I think those things can be helpful, but when people have been through a lot of that, probably not repeating it is a good idea. Then I often move to prolotherapy, which is injecting the ligaments, again, the source of what I see in a lot of chronic pain, with solutions that actually strengthen and tighten the ligaments. And, I do acupuncture manipulation, lots of exercise work, prescribed medicines, but I honestly think that prolotherapy is the most useful tool that I have in my armamentarium for those chronic low backs.
What are the common misperceptions or errors in management of low back pain?
Well, I think one of the things is overprescribing medicines for people, and I think that probably has, a detrimental effect in the long run. The second is the patient not exercising, and that's not necessarily a physician-caused thing. It's very difficult to get patients to exercise, and that's why I aim my exercises to be very simple, just 1 or 2 that people can do throughout the day. And any movement like that can really begin to help. I prescribe an exercise that I call hula hooping that is pretty easy for most people to learn. And again, they can do it 4 to 5 times a day. Just walking is great exercise. People don't need to do a huge amount, but just getting out and walking on a regular basis. And that means getting up from your desk 5-10 minutes every hour and just walking. It's been shown that people who sit at desk jobs all day long don't do well, both cardiovascularly and back-wise as well. And I think the other is what I call partialist or reductionist medicine, and that is looking at an X-ray or an MRI and saying, that's the cause of your pain, that shadow that we see. And without even doing a physical exam or looking at the whole patient, looking at the knees, the hips, in addition to the back and other areas, looking at what the patient does in their life, Are they sitting all day long? Are they lifting improperly? And so discussion and getting a good history on that and modifying those things, I think, are very important. But again, I think the biggest mistake we make is relying too much on our diagnostic tests like X-rays and MRIs.
In summary, what are the key teaching points and where can people go for additional resources?
Sure. I think the key teaching points are that, first of all, in terms of treatment, exercise is probably the number one thing. Getting people moving. If we don't move, we get rustier and rustier, and that's true of our backs as well. 2 is that I think we need to think about ligaments as a cause of pain. And yes, you can see degeneration, and most of us have that, but most people with degenerative disease don't have any pain at all. And it's sometimes some little thing that causes their pain. And again, through careful diagnosis with palpation, one can assess the ligament structures and see whether they may be a cause of the pain as well. And then thinking about treatment, and I would certainly recommend considering prolotherapy in people, injecting the ligaments to strengthen the ligaments and to relieve pain. Additional resources of where people can go. Again, I think the AAFP has material that you can use to give to patients on exercises and whatnot. Getting to know a good physical therapist and what they do, and that means you got to talk with them about what kinds of things they do, because there are physical therapists and there are physical therapists, and some are better than others. And I think the other is looking for courses such as we teach at the University of Wisconsin here on prolotherapy. And there are lots of materials out there, tapes and textbooks now on prolotherapy that might be another useful adjunct to many practices.
Wonderful. Thank you very much.
Thank you.